Hello, everybody. حقيقة I'm so proud and delighted to have Dr. Tarek Elhussein with us here tonight. He is a consultant cardiologist and assistant professor of medicine and cardiac sciences in King Khalid University Hospital. And he's an echocardiologist. He's actively engaged in training, and he's the former program director of cardiology in the same hospital. حقيقة it's a great win to have him in the SCOM. So Dr. Tarek, most welcome. You have the screen and the mic.
Thank you very much, Hatim, for this nice introduction. I'm also glad to be here with you for the first time, and let's hope, inshallah, we can be with you on the long run. طبعا inshallah يعني I've been given this assignment to give a presentation about perioperative assessment for cardiac patients undergoing non-cardiac surgery, and this has been يعني a very controversial topic where most of the people usually they get accountant once they get involved in such assessment. So I'm sure that most of you who are practicing, you will get this at least every day, that you get consulting for patients in the OR or in the clinics or in the wards for patients undergoing surgery and asking you to help them with further assessment and with further plan. So I tried here in this topic just to summarize it and to focus, to highlight on the most important points that you really need to stress on. So if you take it very simple, it's a very simple topic. Otherwise, you may complicate it. So I focused here actually on the guidelines. We have two guidelines actually, the American College of Cardiology guidelines as well the European Society of Cardiology guidelines. And the latest update was 2014, and as you can know now, it's more than 7 years, and there is no much of a major change that affected the guidelines, and actually nothing actually affected it since the year of 2009, and just fewer updates added on these guidelines. So from 2014 until nowadays, no major change happened in the guidelines or the way we are assessing those patients. So remember always the rules. There are rules whenever you are assessing a patient who is going for cardiac surgery, for non-cardiac surgery. So rule number one, actually, that we are not, sorry, just a second. So rule number one, actually, that we are not doing much. So no much of a change, that you are not doing like a big dramatic change that can affect the patient life or survival. Some physicians or surgeons, they think that your magic touch may help and prevent death and consequences that may happen in the OR, but unfortunately that's not the case actually here. So I will explain further more about this, and you will be surprised that 60% of perioperative cardiac assessments done globally are done for medical legal reasons, and sometimes it's done for billing as well. So a lot of unnecessary consultations you may receive in between, but at the end you have to see all your patients and you have to give a clear judgment and a clear statement that is based on evidence-based medicine. So rule number two, actually, that you need to keep it very simple whenever you're seeing your patients and avoid complicating things, and of course try not to do any harm to your patient. So in a stepwise approach, using this slide here, I find it very practical and very, if you look at it in a stepwise approach, so you go it for step on step. So that's very simple. If you keep it, that's form like a roadmap for you whenever you are assessing your patient. So step number one, you ask yourself, is that an urgent surgery or no? Step number two, does the patient have an active or inactive or unstable cardiac condition? Step number three, would there be any risk associated with the surgery itself? As you know, we are categorizing surgeries according to their own risk. And what are the functional capacity of the patient? How much of an exercise the patient can do? And also, very importantly, also to consider the risk of the surgical procedure and the cardiac risk factors that the patient may have, and also consideration for invasive or non-invasive testing. And after all these applications of all these steps, then you will decide and you will give a statement about risk stratification and also whether your patient needs further assessment or you may need to cancel the surgery. So in step number one, always is, does the patient urgent or no? So emergency surgery, urgent surgeries, this is always whenever the life is in danger or a limb is in danger or an organ is in danger. So for example, if a patient comes to you with a massive subarachnoid hemorrhage and you get called for an ECG or come and do an echo, so this is complete unnecessary. So because this has been studied in the past actually, that this may result in unnecessary. So any life-threatening surgical condition that may affect and harm and endanger the life of the patient, so the answer is always proceed to OR and assess your patient after the OR. So remember this very, very, very carefully, because sometimes we get consults from our colleagues in the emergency room or in the surgical floors about the patient, for example, having acute abdomen or having acute appendicitis, subarachnoid hemorrhage, perforated viscous, and they come and ask you to do that and that, have a look on that ECG, have a look on that echo. So these are unnecessarily delays. Always the statements, you should answer them, send the patient to the OR, sign a high-risk surgical consent, and we will see the patient afterward. If that's not an urgent surgery, so it's a surgery that can be performed in more than 24 hours, or it's an elective procedure, you move to step number 2. So in step number 2, you ask yourself, so you get consulted, you saw the patient, whether the patient is having an active cardiac condition or no. So what we call an active cardiac condition, so simply angina. So if the patient has established ischemic heart disease, I need to ask myself whether this patient is stable or unstable. So we consider any patient who is having an acute coronary syndrome or is having unstable angina or having stable angina that progressed to stage 3 and 4. These are all collectively called active cardiac conditions. Patients who are already in heart failure, patients who are already having unstable or uncontrolled arrhythmias, those who have symptomatic obstructive valvular heart disease, and here we are focusing mainly on mitral stenosis, aortic stenosis, and those who had a recent MI within 1 month period. So if your patient has one of these, we consider this is an unstable patient. And in an unstable patient, you need to postpone the surgery, stop the surgery, treat the patient according to your current guidelines, okay? So remember this very well. So let us say somebody have ischemic heart disease, but he's stable angina class 1 or class 2. So would you consider this as an active cardiac condition? The answer is no. What about heart failure? A patient who already have a history of heart failure, but yet now he's functional, he's completely asymptomatic, he's compensated. So this is not considered to be active. Status arrhythmias or cardiac arrhythmias. So for example, patients who is in atrial fibrillation and his heart rhythm is controlled. So this is not active. Symptomatic valvular heart stenosis, and pay attention. So when I say symptomatic severe mitral stenosis or aortic stenosis. So what about mild or moderate aortic stenosis? What about mild mitral stenosis? What about those who are asymptomatic and having asymptomatic aortic stenosis? Still, we consider those as inactive. An MI, which is remote more than 1 year ago or something, is still, and a patient who is asymptomatic, completely functional, is not considered an active cardiac condition. So any patient who have an active cardiac condition, cancel the surgery, treat accordingly. No active cardiac condition, then I move to the step number 3. Step number 3, I have to assess the risk itself associated with the surgery. So as you know, a lot of surgical procedures are divided according to their risk for developing perioperative cardiac events within a 30-day window, and this is collectively putting into consideration cardiovascular mortality and risk of developing myocardial infarction within a 30-day room period. So my focus is on the high-risk group. Those high-risk group actually have the highest risk, which is translated into more than 5% risk of having events within 30 days. So simply, most of vascular procedures that involves clamping, peripheral arterial disease intervention in general, or those who are associated with large volume shift or volume rendering, or those who are associated and they may have significant bleeding as well. So for example, liver resections, transplant surgery, total cystectomy, pneumonectomy. So all of these are maybe associated with large volume shift and bleeding, and all of these may lead ultimately to higher complications. So if my patient has a high risk surgery, I need to do further assessment. But those who have low, intermediate are fine. In general, most of the skin surgery, that like eye surgeries, breast procedures, all these carotid gynecological minor procedures like DNC, whatever, all these are considered low risk, and anything that doesn't fit, we may consider it in the intermediate window. So with the risk of surgery, if the patient has a high risk surgical procedure, then I would proceed to step number 4. But those who have low risk surgical procedure, and remember, we looked at the beginning, so it's not an urgent, it's elective. We then looked at our patient, he doesn't have an active cardiac condition, our patient is stable, is asymptomatic. We looked at the risk of surgery, it is a low risk procedure. Then those patients in general are fine, they can proceed with their surgery and taking into consideration assessment later on. But those who have undergoing high risk surgical procedure, we need to move to the next step. So in the next step, we assess what we call the functional class. And functional class is a very important parameter that you need to look at. Remember, the magic number for the functional class is 4 meds. So anything anything below 4 meds is considered poor functional class. Those with more than 4 considered in general good, 4 to 7 in general. Those who have greater than 10 meds are considered having excellent functional class. So what do we mean by 4 meds? So simply, your patient is able to take care of himself or herself, able to get off the bed, go to the bathroom, and climb 1 flight of stairs at a normal pace. So any patient who can perform these activities, we consider his functional class at more than 4 meds. But those who are bedbound, unable to walk more than 50 meters on ground, they feel very dizzy whenever they go to the bathroom. So these are poor functional class. With those who are having good functional class, we need to proceed as a best. But those who have poor functional class, less than 4 meds, then we proceed to the next step. In those who have poor functional class, with undergoing high risk surgery, we proceed to stage number 6. Those who are undergoing intermediate risk surgery and having 1 or more additional clinical risk factor, a baseline ECG is always recommended for further assessment. So what about individual clinical risk factors? So these are simply summarized in this table. So any patient who have ischemic heart disease, established already, patient who have heart failure defined by any ejection fraction less than 40%, those who have previous stroke or transient ischemic attacks, those who have a baseline creatinine more than 2 milligram, and those who are diabetic requiring insulin. And also I may add here age above 80, okay, according to one of the larger studies before. So if you have any 3 of those category risk factors, we consider the patient as having as high risk for developing perioperative cardiac events. Okay, so if my patient do have more than 3 clinical risk factors, okay, undergoing a high risk surgery, those patients you may consider doing for them non-invasive testing and assess the extent of the ischemia. And those who doesn't have stress-inducible ischemia, they may proceed safely with their surgery. Those who have a significant ischemia by non-invasive testing, like dobutamine echo, myocardial perfusion imaging, those you really need to balance and outweigh the risk, and you need further discussion to decide whether they can proceed safely or not. So I will skip this and come back to it at the beginning. So let's look at some evidence-based medicine. So a lot of people, they consider patient coming from OR like we do, like in, for example, we are Sudanese, and in our culture, any patient who goes to the OR, the moment he comes out of the operating room and start talking to his family that he's safe and he's back, and actually this is not. So this is a very early study, published 1989 in the JAMA, and they looked at the 0 time of surgery and during the induction time, and they measured the level of norepinephrine and epinephrine from the induction to the OR and after the OR. And actually they found that the rapid increase actually occurs during the induction period, and after the OR, the norepinephrine considered to be still elevated and they are steadily high. And this is actually from 0, 6, 12, 18, up to 24 hours. So our patients usually coming out of the OR, successful surgery, they are awake from their anesthesia, still always the risk is there. That's why we keep those patients for careful monitoring, those who are high risk in high dependency unit or surgical ICUs, at least 24 to 48 hours, because during this window, at any point of time, problems can happen because of the elevated norepinephrine level and the associated risk related to that. Because as you know, higher NOR-AP are associated with coronary vasoconstriction. They will lead to alpha effect and the increase in the microvascular ischemia and the load on the myocardium. And also adding to that, the anesthetics and the drugs they use during the inductions, all of these collectively will cause a harmful effect on the myocardium and will lead to cardiovascular risk. What about functional class? So functional class, as we said earlier, we always look at poor versus good. Poor defined as the METs can be performed less than 4. And actually from a very early studies published in the Annals of Internal Medicine, 1999, more than 20 years ago, they looked at the big number of patients, and they looked at retrospectively at only one parameter, which is the functional class. And they looked in those who are poor and good, irrespective of other parameters, and they found that the risk of developing complications if you have a poor functional class is 20% versus 10%, which means we are talking about twofold risk if you have a poor functional class per se, irrespective of other parameters. And this for developing any complications, vascular complications, mainly like myocardial ischemia, myocardial infarction, or cerebrovascular accidents, and also cardiovascular mortality as well at 30 days. So this study highlighted the importance of assessing functional class and the impact of functional class on surgical outcome. What about the interventions that may reduce the risk? So in general, as I said in the beginning, we are not doing much. And I mean, we're not doing much. I will explain to you why. So one of the good drugs that we have as cardiologists are beta blockers. We use them for patients who have coronary artery disease, for those who have heart failure. And it has shown actually in larger scale trials that these drugs are very good in reducing the adverse cardiac events on the long term. What about the perioperative era? In the perioperative era, many trials actually looked at the importance and the significant impact of beta blockers in the perioperative era. We had the DECREASE study and many other studies, the POBIL, the Diacon study. The largest among all these are the POISE, is the POISE study, which is more than 8,000 patients. And that showed actually a significant result in terms of favoring the use of beta blocker in the perioperative events. So in the POISE study, they looked at 8,000 patients. They randomized them into toprolol, which is a sustained release metoprolol. This is not licensed to use in the Middle East, but it's licensed in the USA. It has a prolonged effect and used at a dose of 100 milligram to 200 milligram twice daily. And they gave the patient these in a randomized fashion versus placebo, and they looked at the adverse events. So at 30 days, they found the non-fatal MI was less in the beta blocker arm. The composite of cardiovascular death, MI, and cardiac arrest was also slightly with a statistical trend toward beta blocker. Stroke, interestingly, was higher in the arm who received beta blockers, and incidence of bradycardia was also high. So what do you come up with this trial? We came out with the conclusion that beta blockers are good in preventing non-fatal MIs, but they are bad actually when initiated preoperatively in terms of stroke. They double the risk of stroke and they increase the risk of bradycardia. Bradycardia leading to hypotension and the correlated events. So use of beta blocker from the use of publishing of this trial, because in the past, before this study, we used to give beta blocker for all patients going for high risk surgery, and there was a bad practice at that time that usually people, they used to prescribe it just the day before surgery, and actually that proved to be harmful and should always tailor to the better benefit. So this is the same study looking at total mortality, which was a little bit better in terms of metoprolol. Okay, also taking into consideration the higher risk of stroke, and for cardiovascular death and MI, the hazard ratio was only 0.83. So what was the recommendation for use of beta blocker after this study? So they changed the guidelines in the way that use of beta blockers should always be titrated, and this is preferably, and the optimal is to use it at least 30 days before surgery and not less than a week before surgery. So this is your window for starting. For safety, you should start it at least 1 week, okay, up to 30 days, which is optimal. And this should always target given like bisoprolol 2.5 milligram, achieving a heart rate between 60 and 70, and maintaining a systolic blood pressure more than 100. Beta blockers are recommended for patients who are already having ischemic heart disease, myocardial ischemia in non-invasive testing. So it's not for everybody. It's for those who have already established ischemic heart disease, or those who have who did non-invasive testing and we found that they have significant amount of ischemia. So in those patients, it's a class 1 indication, and to use it within the window we told about earlier. Beta blockers are not recommended for patients who are scheduled for low risk surgery and they don't have any risk factors, and this is of course harmful. So what about the role of statin therapy? Statins in general are very good, but they go with always with their own compelling indications. So there is no indication that you need to start statin only for the sake of surgery. But the point here is that any patient who is already on statin, for whatever reason, primary or secondary prevention, who is going for surgery, the recommendation is always to keep the statin during surgery and after surgery. And more than 6 studies here actually showed that statin therapy is better versus all those who are not receiving statin. So the recommendation is always that you should start it in high-risk patient, optimally between 30 days, at least 1 week. And also those who are already on statin should continue to be on statin. Use of aspirin. Aspirin is very simple. If your patient is already on aspirin, he should continue on aspirin. But the only thing you need to ask your surgeon about the homeostasis related to this. Some patients, some surgeons, they operate safely while their patients are already on aspirin. Some surgeons actually, and this depends on the surgery itself and the risk of bleeding, some surgeons, they prefer to stop the aspirin at least 24 to 48 hours before surgery, and there is no harm with that. So patients can stop it safely and resume it whenever homeostasis is achieved. What about the immediate coronary revascularization to lower the risk? So immediate revascularization, so this has been a debate topic 10 years ago. Like for example, you have a patient scheduled for an elective surgery, you did non-invasive testing, there is ischemia, you send him to the cath lab. In the cath lab, he showed like 70% LAD stenosis. What should I do? Should I stent it and send the patient to surgery? And would that affect and has an immediate or direct effect on the surgery itself? The CARP study actually answered that. They looked at 500 patients randomized to revascularization or no revascularization. And all of those patients were high risk, going for high risk surgery, and they had extensive ischemia on non-invasive testing. And half of them, or 60%, they went to PCI, and 40% they had CABG. And they looked at the immediate effect and the long-term effect. And at 30-day, p-value was not significant. And with extended follow-up, actually up to 6 years, there was no significant difference. So the answer is that revascularization, which is done immediately before surgery, does not affect the outcome. So what about testing? Should I test everybody who comes with shortness of breath? Should I test everybody who has coronary risk factors? So no, the answer is no. Okay, those who need testing are those patients going for high-risk surgery who have poor functional class and have more than 2 clinical risk factors. So remember, they made it very difficult for you. Okay, you need to have these three collectively together to justify doing a dobutamine echo or a myocardial perfusion imaging for your patient. You need to have these three together. More than 2 clinical risk factors, a high-risk surgery, a poor functional class. Having 2 out of 3 or 1 out of 3, it's class 2B. And whenever we say something class 2B, it means that this intervention might be of benefit or even or it's still not clear. So in this case, you need to individualize your decision and take into consideration what is best for your patient. So what about the estimation of patient risk? So I saw a patient, I need to document in my statement, okay, because the surgeon need you to document in the file or in the system, in the electronic records, your assessment for the perioperative. Remember these 4 points that you always need to write it down. You need to write down and document the functional class. You need to document your clinical predictors by means of coronary risk factors, conventional, whether the patient has hypertension, diabetes, for example, hyperlipidemia, you need to document this. The cardiac risk index, according to the index we mentioned before, and also the risk of surgery itself. So remember in the index, we used to give it before the clinical indicators. This is the Lee index. Again, it's published more than 20 years ago. It's a very widely applicable index that we are using nowadays. And as we said, in those who have clinical cardiovascular revised cardiac index, we look at those who have established ischemic heart disease, established heart failure, history of cerebrovascular event, diabetics who are in insulin, and also those who have a serum creatinine more than 2, and the higher risk of surgery. So from the Lee index, we derive that those who have more than 3 risk factors are associated with higher events rate compared to those who have no risk factors and those who have only 1 or 2. So you see the difference here. It's very, very high, and this is a very excellent table. You can use it to identify the risk and to give it in exact numbers. So what about patients who are already have established ischemic heart disease and they did PCI before? This is a very important topic. So for patients who have balloon angioplasty performed, so it's safely, we can perform surgery 14 days after that. Those with bare metal stent, at least we need to wait for 6 weeks. Those with drug-eluting stent, you need to wait within the period that you are all familiar about, which is the 1 year period in which the patient need to be on dual antiplatelet therapy. But with use of newer generation stents, some stents we can actually stop one of the antiplatelet, which is Plavix or ticagrelor, at 3 months and 3 up to 6 months, depending on the type of the stents. But again, this also need to be individualized about the decision, because here you need to take into consideration the surgery itself and the urgency of the surgery. So for example, if you have a patient who is going for a simple hernia repair, he had a drug-eluting stent placed 1 month ago. As long this hernia would not affect the life of the patient, we always advise to be safe and ask the patient to delay the surgery for 1 year, and then after that do it. But on the other hand, if you take, for example, a patient who is having stage 2 CA colon, and his surgery should be performed within 3 months maximum, because staying beyond this period, there will be associated risk of metastasis. So it's in such situation, if I have a newer generation drug-eluting stent which is placed, I can always consider stopping the dual antiplatelet earlier on and not completing the whole 1 year. Devices, remember, interrogation is very important whenever you have an ICD device or a pacemaker. So with pacemakers in general and ICD, the only problem in the OR is the cauterization. So the cauterization, because it will create an electromagnetic field, this may create a noise and affect the device and affect the functionality of the device, especially if it is performed within more than 50 centimeter distance from the region of the device in the left shoulder. So it's always better to ask the surgeon whether they cauterization or not. If they are going to use the cauterization, it's always to do reprogramming of your device. So what reprogramming I need to do? So for permanent pacemaker, I need to change them into VOO mode. The VOO mode is actually a non-sensing mode by ventricular pacing and avoiding or omitting the sensing function. So it will not sense any noise. It will just keep blind pacing during the OR, and after the OR, of course, you can do mode switch back again. Those who have ICD, preferably to do switch the therapy off, because the noise, the ICD may detect it as an arrhythmia, so it may give inappropriate shocks. So it's always better to switch it off, do the surgery, and after the surgery, you can switch it back on. So I think here I'm almost done. I have just a couple of MCQs here to do. So before going into the MCQs, I will leave the floor open for any questions. If you have any question, and then we can proceed.
Thank you so much, Dr. Tarek. Thanks a lot. That was great. Okay, so guys, any questions? Dr. Tarek, actually you have showed us this evidence-based landscape, but back in hospital, we are actually taught into defensive medicine, and we do imaging for each and every patient. You know, there is an alarm kind of, culture among us. But you have mentioned one thing, which is probably we are not kind of so happy to deal with it as per the guidelines, which is the symptomatic valvular. If a patient is having, let's say, severe aortic stenosis and he is asymptomatic, according to your discussion, this is not considered an active cardiac problem and will not preclude stage. So if you would like to elaborate on this.
Thank you, Hatim, for this. That's a very good question. So if we take the entity of severe aortic stenosis, for example, who are asymptomatic, okay, let us ignore that those patients are going for surgery. An asymptomatic severe aortic stenosis, the guidelines say to you, do not change the valve for those patients and wait on them. And provided that they have a preserved ejection fraction, they have within normal LV volumes, and they are completely asymptomatic. And this actually came from evidence-based that those patients actually, the of sudden death actually is similar to the general population. So if you consider the risk of surgery itself, which is 1 to 3%, okay, irrespective of other comorbidities, compared to risk of death as a normal population, which is less than 1%. That's why, taking into consideration these two parameters, we tend to prefer and wait on those patients. So those as an entity are considered very low risk patients. So here, I would really, what I would do, I would really look into the surgery itself. If it's a surgery that really need to be done, I would not argue actually against it. I will let it go. A lot of patients actually came before with having cancers and having major eye surgeries affecting their vision, and they did the surgery and it went very smooth. But whenever you have symptoms, as you know, in the aortic stenosis cascade, symptoms, the 3 cardinal symptoms, which are syncope, exertional dyspnea indicating heart failure, and those who have angina. As you know, by the time we develop onset of symptoms, it's no longer the annual death is 0.1%. Now we move to 5%, and we build up with the with time. So and look at mortality for those, for example, who have exertional dyspnea. So we have a mortality which is 50% in a 2-year period, compared to those who have syncope, which is 50% in 3 years, compared to those who have chest pain, which is 50% in 5 years. So if you look at all these data collectively, you can actually come up with a conclusion that I can send those patients. But it's whenever you can delay it, the surgery is not important, the patient is convinced to change his first, okay? It's always better to do this. This is actually the practice that we tend to do.
يا طارق السلام عليكم. طارق.
وعليكم السلام.
ايوه thank you so much. الحقيقه انا جيت شويه ليت، احتمال you answer my question during your talk، لكن just انا حضرت يعني الجزء الاخير من your talk. In the example you gave, for example, the patient has CA colon, and if you wait more than 3 months, the chance of metastasis is there. So if this patient has an old generation stents, like left main stent, or I mean like the proximal LAD or something like that, what you will do in this situation if you want to, I mean, to interrupt him in the dual antiplatelets? How you approach, I mean, such patients?
Yeah,
and we
thank
face
you,
in our practice we face يعني such patients صراحة.
Yeah, a lot of patients actually, and that's why in such patients we always tend to individualize the decision, and these kind of patients are always preferably to be discussed in a heart team. And that's what we are doing actually, because you need to develop a consensus always in those who are very high risk patients, in whom you cannot delay the surgery, and at the same time you need to save the stent that is placed there. So of course, for those older generation stents, usually we tend to wait for 1 year, but for the example you already given, waiting is actually, it means that metastasis may happen and the patient may become not operable, because you know, like for example, CA colon at stage 2, it's a completely curable disease. If you wait and stage 3, it's no longer a curable disease. So in those patients, some interventions done in small studies, and actually we did it in few patients in our hospital, that we give them like glycoprotein 2B3A inhibitor. We give it like 48 hours before the surgery, and we stop it 12 hours before the surgery. And as you know, if you stop it 12 hours, especially like agrastat, for example, you will have the plasma effect is gone, and then we send them for surgery, and then we resume the antiplatelet right after surgery. Of course, this hasn't been studied widely. There is no randomized trial that looked into that. Fewer case series are published, like case control studies, and actually it's one of the practices that you may apply, and it may have a good outcome also.
And same thing يا طارق regarding, I mean, regarding intercerebral bleed, GI bleed with the place stent, I mean the stents in place. Also, always, I mean, these patients are really, we are facing it almost every day. Our practice also is a big problem, really.
Yeah, you are absolutely right. There are always difficult cases that really need to always have a consensus and have multiple opinions, multidisciplinary team, hard team discussion to reach a consensus. But the thing here is we're trying to give it to the fellows and to the most junior staff that always you have the guidelines, you have the roadmap, try to follow that as much as you can. If you face a difficult patient, always discuss it, always take opinions and develop a consensus.
Yes, okay. Thank you, Tarek.
Yeah. That's why actually hard team is now +1 indication, because there are so many tricky situations where you are confronted with challenging scenarios and you can't sort out or navigate your way by single-handed decision. So you have to team up with whoever is concerned of this patient. Like in this patient, the oncologists are important to tell exactly how safe to wait and stuff like that. In the bleeding scenarios, we also need to hear from the gastroenterologist and stuff like that. And actually, like in our practice here in hospital, we have managed to make a cardiorenal service, and that was actually a great refinement of care. And we realized that these cohorts of patients are kind of very specific and has to be dealt with in a joint kind of meeting between the nephrologist, transplant surgeon, and the cardiologist. And this meeting actually is so different than just telling them your point of view. It's always wise to team up with the concerned parties and reach a consensus about it. This is really great. Dr. Tarek, just because I see that the fellows are not yet ready for questions, the CARP trial. Because this CARP trial is a kind of landmark, very courageous trial, because all these patients have significant sort of ischemia, but some of them went for medical therapy and the other for PCI or revascularization in general, and there was no difference between the two groups, or actually there was a trend towards harm in the revascularization. I just want you, I just want you to put this trial in your mind, because Dr. Tarek has mentioned it clearly. We are not really doing much. We are not really doing much. You know, all this kind of preoperative evaluation is more of allaying anxieties of surgeons and anesthetists, rather than doing any solid kind of management that prepare the patient in better ways for sleep.
Yeah, exactly. As Dr. Hatem mentioned, that's what I tell my fellows when they get anxious with getting over and overwhelmed by the consultation service for all patients going to OR. I tell them only one statement, that in our practice, sometimes you need to treat the anesthetist, you need to treat the surgeons, not necessarily treating the patient, actually. So relieving anxiety of other colleagues is part of what we are doing, actually. And also the medical legality. Remember, as I said, 60% are done on medical legal. And this is not only in our part of the world, actually. If you go to the USA and Europe, it's always like this. Some people, they just do it to protect themselves, like the anesthetist. They try to drag the feet of the cardiologist. So if they screw up with the patient, whatever happens, people may ask them later and tell them why you did not consult the cardiologist, considering that the cardiologist, they might have done something magic to the patient and save his life. But again, as I told you in the beginning, we're not doing much. So make it very simple. So any more? Marhaba wa sahlan.
Excuse me, after prayer I came a little bit late, but just I want you to clarify for me something. Example, if I have a patient of 7.
May I know? Can you introduce yourself, please?
If I have a patient with of 70 years old, hypertensive or amlodipine, and he came with prosthetic symptoms, and the urologist planned him for prostatectomy. On the preoperative workup, as an assist, they asked for ECG and they found that having atrial fibrillation, but it's rate control, and he was maintaining his vitals. So if they can proceed for the surgery or they may delay for something.
Okay, so he's 70 years old, he's diabetic.
No, hypertensive on amlodipine.
70 years old, hypertensive. Like, let's take it. Yani, we can answer it very simply. Let's do it in our stepwise manner. So, is it an urgent surgery? No, it's a prostatectomy, is that?
No.
So it's a prostatectomy. It's considered an elective surgery. Does he have an active cardiac condition? The answer is no.
No.
So your patient doesn't have an active cardiac. What is his functional class? Is asymptomatic?
Yeah, asymptomatic. Accidentally, they found that having atrial fibrillation.
Okay. Is he able to climb one flight of stairs?
Yes.
Okay, so he's good functional class. What about the surgical associated risk? So prostatectomy is considered a low to intermediate risk procedure. It's not a high risk procedure. And the clinical risk factors that the patient have in here is only hypertension. And his age is 70, so it's not a clinical risk factor. So he's a low risk patient, asymptomatic, with a good functional class, going for a low to intermediate risk surgery, who have an atrial fibrillation that is controlled. So it's not an active cardiac condition. So my answer to you is that your patient can proceed to the surgery safely.
Regarding the anticoagulation, because his CHAD score is 2 at least.
With regard to anticoagulation, as you know, your patient, you need to take the CHAD VASC score for your patient and decide accordingly. For surgery, for the surgery itself, the patient should be off anticoagulation because, as you know, for whatever indication, during the surgery period, the patient has to be off anticoagulation. So the patient can proceed to surgery safely, okay? And then afterward, after he achieves homeostasis, you can start then afterward the anticoagulation, which is on the long term.
Okay, thank you so much.
Thank you so much. So if no further questions, we can proceed to the MCQs, Dr. Tarek.
Okay, so no more questions. So let's proceed. I would like to hear the comment. You can write in the chat box. Okay, this is an MCQ. So it will tell me and tell you how much did we understand from this presentation. So let's start with the first one. All of you can just write A, B, C, or D. So that's a 76-year-old gentleman who has a symptomatic severe aortic stenosis. He's admitted with an abdominal pain and diagnosed to have a rupture of a AAA, and he was unsuitable for endovascular aneurysmal repair, and the surgeon called you for an assessment. So what would you do? So would you say to them, proceed with the AAA repair surgery, or you need to perform balloon valvuloplasty before surgery? You need to treat him medically or none of the above. So let me see the responses. Please, all of you try to put your responses. So we have one said A. Let's see the rest. يلا يا شباب كلكم اكتبوا whatever you know or you don't know. Don't worry. So Iman A. Iman A. Mona Ismail A. So I'm getting most of you are saying A's. Let's see what's the correct answer. So you're all correct. It's A. Why it's A? Although the patient has a severe symptomatic aortic stenosis, which is an active cardiac condition, if that patient was going for an elective surgery, then what would I do? I will cancel it, postpone the surgery, and treat him, fix his aortic stenosis first. But this patient is going for an emergency surgery. So irrespective of his condition, he should always proceed to surgery. Second question, 62 years old gentleman with end-stage renal disease. He's diabetic hypertensive. He's been evaluated for a renal transplant. ECG, LVO motion, echo is normal. Ejection fraction 65%. His stress echo was negative for ischemia. And on the insistence of the renal transplant committee, he had a coronary angiogram that showed 70% mid-LAD lesion. So what has been shown to reduce the risk of perioperative cardiac events in this patient? An LAD drug-eluting stent, Lima to LAD, perioperative beta blocker, none of the above. So please write you in the chat box. See any other responses?
Come on, guys. We need all you to respond.
Come on, يعني write whatever you think يعني ما في إحراج يا شباب. So I'm getting varied responses between C, D, and A. So let us look at our patient. Remember, we said about what is the class 1 indication for beta blockers. I need to have the three together. So the first is more than 2 clinical risk factors. So our patient has diabetes, has hypertension, so more than 2. Second thing, the patient should be going for a high-risk surgery. Renal transplant is considered a high-risk surgery, so this is 2. And the third thing, I need to have extensive ischemia in the non-invasive testing. So the patient here did not have an extensive ischemia non-invasive testing because his stress echo was normal, okay? But it was found only on a coronary angiogram that was not done, okay? To start with, as a class 1 indication, a 70% mid-LAD lesion. And that tells you that whenever we give 70-60%, this is always visual assessment. So this assessment, not necessarily that every 70% that is anatomically significant should be physiologically significant, okay? So our patient does not fulfill the class 1 indication for going the blocker, and the answer here is D. It's a tricky question, okay? Results of the POISE trial addressing perioperative beta blocker yielded which of the following results? Use of beta blocker reduced risk of AFib, use of beta blocker reduced risk of MI, beta blocker use resulted in high risk of stroke and non-cardiac death, all of the above. So let me see the responses. D, D, D. So majority are giving D, and the answer is correct. So use of beta blocker reduce risk of AFib, reduce myocardial ischemia, and non-fatal MI. But on the other hand, it will increase the risk of stroke and non-cardiac death related to bradycardia and hypotension. And this risk is actually directly proportional to the age. So in older patients are more prone to develop complications compared to younger patients. Okay, so remember, especially use of beta blockers in the elderly population. In a patient with stable coronary artery disease, who's been on aspirin, beta blocker, statin, he's undergoing AAA surgery. Which of the following would you recommend to reduce risk of perioperative cardiac ischemia? Myocardial ischemia. Continue beta blocker, continue statin, continue aspirin if possible, administer perioperative prophylactic intravenous nitroglycerin, all of the above, A, B, and C. So we have F, one response. يلا يا شباب. A, F, F. The correct answer is F. So as we mentioned before, those who have already on beta blocker because of coronary artery disease should continue. Aspirin should be continued if possible. Statin should always be continued. Use of intravenous nitroglycerin, there is no benefit. Actually, there is a tendency of harm, and all of the above is also wrong. So asymptomatic patient with severe aortic stenosis, normal LV function, peer pressure, scheduled for knee replacement. What would you recommend? Valvuloplasty before surgery, TAVI before surgery, proceed to surgery with close hemodynamic monitoring, proceed with surgery and beta blockers. يلا يا شباب. So I'm seeing here only one response, which is C so far. Let's look at the responses of the others. Okay, C, C, C. So let's see the answer. The answer is C, excellent. So this is a severe aortic, but the patient is asymptomatic. And he's going for a knee replacement, which is considered low risk. يعني حسب الcomorbidity or obesity, it may go to intermediate risk. So it's not a high risk surgery. So the patient can safely proceed with close hemodynamic monitoring. Thank you very much. وبالتوفيق إن شاء الله.
Thank you so much, Dr. Tarek. Thanks a lot.